Sir, today I am talking about the evaluation of late effects of bone marrow transplantation and CAR T cell therapy. The late effects are included following the chronic graft versus host disease and infertility and delayed puberty in females, impaired growth and development, total body radiation and second malignancies, and intellectual impairment, CNS-directed therapy. Now coming to chronic graft versus host disease, chronic GVHD is the most relevant use of late non-relapse morbidity and subsequent mortality. Approximately 25% in the following allogeneic hematopoietic stem cell transplant. Its incidence approximately 50% among all patients following LOHSCT and has increased during the last two decades due to increasing patients' age and increasing use of unrelated or mismatched donors. Reduced intensity conditioning of regimen and peripheral blood stem cell collection. The incidence of chronic GVHD is lower in children and as 20 to 40%, and the rises to 60% as the patient age is increased. Now coming to risk factors of chronic GVHD. The unrelated and mismatched donors are the most probable risk factors, and PBSCS as donor source and older donor age, and when a female donor to male recipient, use of total body radiation, and by far the strongest predictor is the history and severity of acute GVHD. They are the clinical manifestations of chronic GVHD. Chronic GVHD usually begins between 3 to 2 years after HSCT, but now earliest onset at 1 month after transplantation of HSCT is possible. And a skin manifestation may overlap with acute GVHD like erythema, megalopapular rash, and pericarditis. Chronic GVHD of the eyes usually manifests as keratitis sicca. Light sensitivity is the prominent system, sometimes with excessive eye rubbing. And in oral cavity, sicca symptoms may result from destruction of the salivary gland, and long-term chronic GVHD may lead to conjunctivitis. In liver involvement manifests as a cholestasis and may resemble primarily biliary cirrhosis, but hepatitis forms with high transaminases are also possible. Now coming to severity and grading of chronic GVHD. Grading is divided into three categories: first, mild and moderate and severe. Number of in which the number of organs, only 1 to 2 is called mild, and more than 3 to moderate. And if 3 organs involved with lungs is called severe. Now coming to treatment of chronic GVHD. Mild chronic GVHD does not impair organ function. The use of topical steroids, topical and phototherapy should be considered. Impossible PRD treatment and initial dose of 0.5 to 1 mg per kg as body weight of patient is recommended. Topical ice can be used in addition to system to improve efficacy for moderate severe GVHD. Systemic treatment of with PRD of methylpyridine at an initial dose of 1 mg per kg body weight per day should be used. Now coming to the grading and grading of treatment. The steroids class 1 and as the renal toxicity, fraction, hypertension, and rituximab steroids, and MMF, mecofenolate, mofetil steroids, and azithromycin and thalidomide and should be used. That is the second line therapy: steroids, abiraterone, and photopheresis, MTORNH, and sirolimus, everolimus, and mecofenolate, mofetil, and rosalimus, etamivir, and thalidomide also. Secondary malignancies of chronic GVHD. The incidence of solid tumors in the recipients of allogenic HSCT and increase compared with control population and include a higher risk of skin and buccal cavity. A risk factor for the development of secondary malignancies include the use of total body radiation in the conditioning regimen and the presence of chronic GVHD. Now this is the growth, puberty, and fertility. Recording growth is seen predominantly in children who received transplant as a younger age, more than 10 years, and those who have received radiation, particularly cranial radiation. And growth retardation is multifunctional, and although growth hormone levels may be dysregulated consequence of thalidomide. Although about 10% of women who received total body radiation containing regimens may have some recovery of gonadal function, the overall incidence of pregnancy is very low. The advent of recipient of radiation content raises the prospect that some women may remain living at the transplantation, and in this case, career therapies will be additional factors determining infertility. And in males, cryopreservation of sperm should be performed at diagnosis, since chemotherapy and transplantation both result in a high rate of male infertility. Now coming to late effects of CAR T cell therapy. According to Food and Drugs Administration has approved CAR T cell therapies targeting CD19 and relapsed and refractory B-cell acute lymphoblastic leukemia, ALL, and aggressive B-cell non-Hodgkin lymphoblastic NHL, and mantle cell lymphoma based on an impressive response rate and response durability in this difficulty to treat patient population. The advert CAR T cell therapy has resolved the treatment of relapsed factory and hematologic malignancies. Is that hypogammaglobulinemia defined as immunology when IgG level less than 400 mg per dl or the need for immunoglobulin. The replacement of due to recruitment infection is the most common late adverse effect of CTL019. Approximately 35% of patients have baseline hypogammaglobulinemia, likely secondary to underlying disease and previous therapies. And in a long-term follow-up study of CD19 directed CAR T cell therapy in relapsed refractory B-cell NHL and 60% of patients have globulinemia beyond 19 days. The incidence of hypogammaglobulinemia is higher in patients with B-cell ALL after CAR T cell therapy. The recovery of B-cell in peripheral blood is not always associated with rise in IgG production post CAR T cell therapy. And much the monthly immunoglobulin replaced with IVIG or a subcutaneous formulation 400 to 600 mg per kg as body weight operation is frequently offered in these patients with who's with goal IgG throw levels more than 400 mg per dl, particularly if recurrent of severe infection. And closely monitoring of IgG is very much level and disconnecting the IgG once the throw levels is persistency 400 mg per deciliter without replacement is a rational strategy. T cell depletion also may remain impaired after CAR T cell therapy, and checking for CD4 and CD8 T cell substitutions in peripheral blood can also aid clinicians as assessing immune recovery. And now recovery and screening and preventive care. Obtain serum IgG level monthly beyond day as 30 after CAR T cell infusion and until IgG more than 400, less than 400 mg per deciliter. Consider obtaining IgG substitute level is active infection despite total IgG more than 400 mg per deciliter. And now come to prolonged cytopenia. Prolonged cytopenia involving all three cells lines after CAR T cell therapy have been described in both clinical trials and observational studies. The prescribed mechanism behind prolonged cytopenias remains unclear, with bone marrow biopsy demonstrating hypocellular therapy in most cases. In Zuma, one trial, 18 out of patient as 108, 70% had grade 3 or worse cytopenia beyond 3 months, with neutropenia in 11%, thrombocytopenia in 7%, and anemia in 3% also. However, at a median follow-up of 27 months, only 2 patients had grade 3 cytopenia, one with anemia and one with thrombocytopenia, indicating that most cytopenia resolve on long-term follow-up. The burden of grade 3 or worse cytopenia beyond 1 month is greater in RRB cell LL trials. A management of prolonged cytopenia, blood product transfusion, and use of GCCF support and thrombocytopin receptor against erythrothrombin and prophylactic antibacterial and antifungal agents in patients with prolonged neutropenia. Now, recommended screening and preventive care. CBC with differential at least within every 30 days after the acute phase of CAR T cell therapy and until normalization of blood counts. Late infection, both hypoglobulinemia and prolonged cytopenia can lead to increased risk of late infection in CAR T cell therapy survivors. The most common site of infection was respiratory tract in the eliminated the trial 18 after 40 B cell ALL patients with prolonged neutropenia beyond at least day 28 developed grade 3 or 4 infection. Some atypical infection were also noted, including pneumococcal 6, encephalitis, and systemic mycosis. Management of prolonged cytopenia. One of the key aspects of infection management beyond 30 days after CAR T cell therapy is prevention and early detection. Second, now for prevention, antiviral prophylaxis can be started with acyclovir, beginning with lymphodepleting and chemotherapy and continuing through at least 90 days of post-infusion. Continuing antiviral prophylaxis up to 6 months post-infusion is also a reasonable approach. And ciprofloxacin can be used for antibacterial prophylaxis beginning on day 0 and continuing until recovery of absolute neutrophil count. Antifungal prophylaxis can be used with fluconazole, should be initiated during the neutropenia period and switch to a mold active agent such as phosphoconazole should be considered if the patient requires prolonged high dose corticosteroids as prolonged neutropenia less than 3 weeks. Prophylaxis for PCP, pneumocystis jersemia with thrombocytopenia sulfamazole and should be continued until CD4 plus T cell count is greater than 200 cell per ml. Some experts recommended continuing PCP prophylaxis until at least 6 months. It is recommended that administered killed or inactivated vaccine beyond 6 months and live vaccine in 1 year after CAR T cell therapy. Screening for this CD4 plus T cell count monthly beyond at least 30 days until CD4 count is more than 200 cells per ml. Now, late neurologic events, acute neurotoxicity, cytokine release encephalopathy syndrome, immune effectors, cell-associated neurotoxicity syndrome is a well-known adverse event early after CAR T cell therapy, with onset of symptoms by 5 days after infusion. A clinical manifestation includes confusion, aphasia, ekpharia, ataxia, memory loss, and hallucination, and apraxia can be occurred to patient. 3 distinct patterns of neurologic symptoms have been reported after CAR T cell therapy. One that is concurrent with CRS, and another that occurs shortly after CRS subsides, and a third form with a delayed onset to 3 or more weeks after CAR T cell infusion. Management of CAR T cell infusion, supportive care. Management directed to specific adverse events, and there is a lack of data on the management of late neurological events, including the utility of a corticosteroid or an anti-IL-6 monoclonal antibody in this context. Screening and prevention for this clinical evaluation for signs and symptoms of neurophysiologic and dysfunction monthly after 30 days with diagnostic tests. Objective neuropsychological testing brain will also be must. Immune-related late effects might be reaction with the development of now separation of P16 autoimmune disease as a potential concern after CAR-T cell therapy, similar to the data seen with the immune checkup point with an individual. Management of this based on available data for the treatment of immune-related adverse events of ICLS, including transient immunosuppression by administration of glucocorticoids, is a rational strategy. The patient's skin rash not responding to steroids can be subsequently treated with UVA phototherapy. Study prevention from this clinical evaluation for signs and symptoms of immune-related adverse events such as pneumocystis or colitis at least every 1 month of 1 month until 1 year and every 6 months thread after the and targeted diagnostic the clinical suspicion. Subsequent malignant in the long-term follow-up to the ZUMA-1 trial, one patient developed myelodystracted and syndrome MDS at the 19 months, which was the attributed to previous cytotoxic therapy. In phase 1 and 2 study from Friedrichshain Cancer Research Center, subsequent hematological tests were seen in 5 patients, 6%, including 4 cases of MDS and 1 case of MM. Medium time from CAR-T cell therapy cell infusion to diagnose of MDS was 6 months, range 4 to 17 months. Furthermore, 2 of the 4 patients with MDS had pre-existing cytogenetic abnormalities before CAR-T cell therapy. And given that these patients had received the extensive previous cytotoxic, the REPS is the nuclear particular CAR-T cell therapy can be attributed to develop of subsequent cancers. Management of this cancer surveillance for hematopoietic stem cell transplant specific guidelines. Age-appropriate cancer screening among patients in CR, rollout therapy-related myeloid and neoplasm in patients with prolonged cytopenia. And the secondary malignant because of other area events with potential long latency, long-term follow-up of ongoing clinical trials and epidemiology data on needed to actually estimate the incidence of second cancers. The Food and the Food and Drug Administration has mandated at least 15 years follow-up for XCL and the designated in these prospective post-marketing registry studies being concluded by the submit the incidence of subsequent malignancies as a key endpoint. Screening and prevention, age and sex appropriate screening for solid cancers and periodic monitoring of blood counts of screening for therapy, related myeloid neoplasm and low threshold to perform bone marrow examination in patients with unexplained or worsening cytopenia. Now coming to the nursing care, nurses have a significant role in coordinating for post-bone marrow transplant patients, identify useful resources for patients and develop post-transplant services for patients, ensure the care meets the need and the concern of patient, develop innovative roles and individual practitioners as a part of a wider multidisciplinary team, develop the evidence based by leading or participating survivorship research, and develop creative ways of working and providing suitable clinical and supportive care to patient. Always, nurse should pay attention on mouth care, sore throats, swollen glands, and hair loss, darkening, and dryness of skin, diarrhea. Neurological assessment is most important for the post-hematopoietic stem cell transplant patients. Nurses can assess the status by using any neurological assessment tools. Thanks. There's any question?
Thank you, Ajit. Yes. Yeah. Any questions? I know your presentation was of a complicated topic that we don't do CAR-T cells either in India or Pakistan, but Of course, it's something that is required by the JC standards, that you have an idea. Any questions from anybody? Marco, you do it in Genova, right?
Yes, sorry, can you repeat?
You do CAR T cells in Genova.
No, in this moment, no. You have, you are awaiting the reaccreditation of JC. There is a problem with some label, but we have the room already prepared for the CAR cell with all the monitor, all things, but don't have still the accreditation to prepare the CAR T. We are waiting the accreditation.
Okay, thank you. Renita, can you hear me? Renita?
Yes, I'm here.
Oh, hello, Renita.
Hi.
Renita, are you in San Francisco?
Yes.
Oh my God, this is 5 a.m.
Yeah.
I'm really impressed. Yes. So I'm sure you do CAR T cells, right?
Yes, we do
You do?
quite a few CAR T
Okay.
cells. Yeah.
Do you want to make any